Hey everyone, and welcome. Today we are jumping into one of the most critical topics in all of medicine, the stroke. You've probably heard it called a brain attack, right? And honestly, that's the perfect way to think about it. It's a sudden, life-threatening emergency where every single second is absolutely crucial. So let's break down what that really means. So here's how we're going to tackle this. First up, we'll get a solid definition of what a stroke actually is. Then, we'll look at the two main ways a stroke can happen, the two different pathways. After that, we're going to pull out a map of the brain's plumbing, which is key to understanding why symptoms show up where they do. We'll connect that anatomy to the clinical signs you'll actually see in a patient. And finally, we'll talk about that frantic race against time to treat a stroke once you've spotted it. Okay, let's dive right in. The absolute fundamentals. What are we really talking about when we say the word stroke? Well, at its very core, it's a desperate race against time for the brain. At the end of the day, a stroke is basically a plumbing problem in the brain. The blood flow to a certain part of the brain either gets drastically reduced or it's cut off completely. And without that constant flow of oxygen and nutrients, brain cells, well, they start to die. And they die fast, within minutes. This cell death is what causes the long-term, sometimes permanent disability we see with strokes. Now this right here, this is the central battleground of any stroke treatment. On one side, you have the core infarct. You can think of this as ground zero. It's brain tissue that's already dead, and unfortunately, there's no bringing it back. But surrounding it, you have this area called the ischemic penumbra. Now this tissue is in serious trouble. It's weak, it's struggling, but it's still alive. This is our target. This is the part of the brain we are racing to save. If we can get that blood flowing again, and fast, we can rescue the penumbra and dramatically limit the damage. Now, all strokes are caused by that interruption of blood flow, but they happen in two very, very different ways. And understanding this difference is everything, because the treatments are basically polar opposites. One will help, the other could be catastrophic. And this chart, wow, it lays it all out, doesn't it? The vast majority of strokes, a full 85%, are ischemic. That means they're caused by some kind of blockage. Only about 15% are hemorrhagic, which, as the name suggests, are caused by a bleed. So let's get into the mechanics. An ischemic stroke is like a dam suddenly appearing in a river. A clot or some other debris gets lodged and stops blood from getting where it needs to go. A hemorrhagic stroke, on the other hand, is like a pipe bursting. A weakened blood vessel ruptures and blood starts leaking directly into and around the brain tissue, causing a ton of damage from all that pressure. All right, so to really get a handle on stroke symptoms, you've got to understand the brain's geography. You have to know the map. Knowing which arteries feed which parts of the brain is what lets you look at a patient's symptoms and predict exactly where the problem is. So the brain's blood supply has a main highway system, and we call it the anterior circulation. It accounts for about 80% of the total blood flow. This whole system starts with your big carotid arteries in your neck and feeds the front and side parts of your brain. You know, the areas that handle things like your personality, movement, sensation, and language. The other 20% comes from the back, from what's called the posterior circulation. These are the vertebral arteries, and they run up through your spine. Now, 20% might not sound like a lot, but this circulation supplies some of the most critical real estate in your head. The brainstem, which controls all your basic life functions like breathing, the cerebellum, which is all about coordination, and the occipital lobe, which handles vision. And this is where the brain's design is just, honestly, it's brilliant. It has this incredible built-in safety feature called the circle of Willis. You can picture it like a traffic circle right at the base of the brain that connects the front and back systems. So if a major blockage happens in one of the main arteries before the circle, it can actually reroute blood from the other side to help out. It's like a fantastic backup generator for the brain. Okay, so we've got the map. Now let's connect it to a real person. When a specific artery gets blocked, it creates a really predictable pattern of symptoms. We call this a stroke syndrome, and it's like reading a set of clues. A classic sign of a stroke is aphasia, which is just a fancy word for trouble with language. And the mnemonics here are your best friends, seriously. For Broca's aphasia, just think Broca's is broken speech. The person knows exactly what they want to say, they just can't get the words out smoothly. For Wernicke's, think Wernicke's is word solid. They can speak just fine, the words flow, but they're all jumbled up and don't make any sense. Now, another huge sign, especially when that posterior circulation is involved, is ataxia. And it's super important to remember this is not weakness. It's a coordination problem. Remember how the cerebellum controls balance and precision? Well, a cerebellar stroke will make someone look clumsy, have trouble walking a straight line, or misjudge distances when reaching for something. That last one is called dysmetria. Okay, this slide right here, you're going to want to tattoo this to the inside of your eyelids. It's so high yield. It connects the artery directly to the symptoms. For an ACA stroke, think A for ankle. The weakness is way worse in the leg than the arm. For an MCA stroke, the most common one by far, think M for mouth. The weakness hits the arm and face hardest, and this is where you see that aphasia. For a PCA stroke, think P for perception. You're going to see all sorts of vision problems. And for a cerebellar stroke, just think C for coordination, which points right to that ataxia we just talked about. So, how can you spot a stroke out in the real world? What can anyone do? Well, there's this simple but incredibly powerful tool called the FAST exam. F is for face. Ask them to smile and see if one side droops. A is for arms. Have them raise both arms and see if one starts to drift down. S is for speech. Ask them to say a simple sentence and listen for slurring. And T is for time. If you see any of these, it is time to call for help immediately. And that brings us to the final and maybe most intense part of our journey, the race to treat. Once a stroke is suspected and that patient is headed to the hospital, that clock starts ticking louder and louder. So, the patient rolls to the emergency room doors. Before anyone does anything else, there is one question, just one, that overrides everything. Is this an ischemic stroke from a blockage or hemorrhagic stroke from a bleed? You have to know the answer, and you can't tell the difference just by looking at them. And the only way to answer that question is with a non-contrast CT scan of the head. Now, here's the key point that trips a lot of people up. The CT scan's main job isn't to find the blockage. No, its number one job is to rule out a bleed. A fresh bleed shows up on a CT scan instantly, like a bright white light. An ischemic stroke, the blockage, that might not show up at all for 6 hours or more. So if a patient has clear stroke symptoms and their early CT scan looks normal, that tells you it's an ischemic stroke. So if we've ruled out a bleed, our mission becomes crystal clear. We know we're dealing with an ischemic stroke, and our one and only goal is to get blood flowing back to that salvageable penumbra we talked about as fast as humanly possible. Our main weapon for this is a powerful clot-busting drug called TPA, but you can't just give it to everyone. It comes with some very strict rules. The biggest one is the time window. It has to be given within 3 hours from when the symptoms first started. We also have to know for sure there's no bleed on that CT, the patient's blood pressure is under control, and that they don't have any other big bleeding risks. It's a high-stakes checklist. But what happens if the symptoms just go away on their own? That's what we call a mini-stroke, or a transient ischemic attack, a TIA. And you absolutely cannot just ignore it. Think of a TIA as a huge warning shot from the brain. We use this tool, the ABCD2 score, to figure out how likely it is that a person will have a full-blown stroke soon. We look at their age, blood pressure, clinical signs, and the duration of their symptoms. A high score means a very high risk, and we need to act. So, if you remember just one thing from all of this today, let it be this. In stroke care, time isn't just important, time is everything. Time is brain tissue. Every single decision, from the person who first recognizes the signs and calls for help to the team waiting in the ER, is driven by one urgent guiding principle. Time is brain. Look, this knowledge is a superpower. It can literally save a life or prevent a lifetime of severe disability. So the next time you see someone suddenly develop weakness on one side or start slurring their words, you'll know what might be happening. You'll know what's at stake, and you'll know exactly what to do. You'll remember to act fast.